And it looks like Brian already started recording. So why don't we go ahead and get started? So welcome to the Psychiatry Department Grand Rounds. My name is David Jensen, and I am one of the psychiatry residents. I'm in my 4th year of residency here. And it's my pleasure to introduce today our speakers from the Addiction Science Center at East Tennessee State University. They will be talking about state, regional, and national trends in substance use disorder and the impact of COVID-19. Let me go ahead and introduce both of our speakers individually. So first we have Dr. Robert Pack. He's a professor of community and behavioral health, as well as Dean for Academic Affairs in the College of Public Health at ETSU. Also serving as the Executive Director of the ETSU Addiction Science Center. Additionally, Dr. Pack serves on the boards of One Tennessee Health, a Step Ahead Foundation, Tri-Cities, and as Chairman of the Board of Directors of Overmountain Recovery. In 2019, he served on the Appalachian Regional Commission Substance Abuse Advisory Council and chaired the Association of Schools and Programs in Public Health Task Force on Public Health Approaches to Control the Epidemic of Opioid Use Disorder. The task force report, Bringing Science to Bear on Opioids, released in November 2019, is intended to be used as a resource for all parties involved in a multi-district litigation proceeding against opioid manufacturers, distributors, and pharmacies. Our second speaker today is Angela Marie Hagaman. She serves as the Operations Director for the ETSU Addiction Science Center. In this role, she serves as the Principal Investigator for the Tennessee Opioid SBIRT project at ETSU Family Medicine, the Program Director for the NIH-funded studies to advance recovery supports, also known as STARS, and the Program Manager for the ETSU NORC Rural Health Equity Research Center. Ms. Hagaman is a candidate in the Doctorate of Public Health program at ETSU, and she is also a National Certified Counselor. Also instrumental in the presentation today, but she will not physically be here to participate in the presentation, is Dr. Stephanie Mathis, who is the Research Assistant Professor in the Department of Community and Behavioral Health, and is a research faculty with the Addiction Science Center. I do ask that everyone, as you're joining, please mute yourselves to prevent any background noise, and recall that you can use the chat feature at any time during the presentation to collect questions for our guest speakers to field at the end of today's presentation. And so without any further delay, it's my pleasure to introduce our speakers today, starting with Dr. Pack. Thank you.
Thank you so much, Dr. Jensen. Really appreciate that kind introduction. I'm Rob Pack. I'm delighted to be here with you today. I've been a faculty member here at ETSU and actually serving as Associate Dean here in College of Public Health since 2008. I know many of you on the call, I think, and count some of you as collaborators. I'd like to count all of you as collaborators because there's so much that we can do together in this region on this topic. Today we'll share some just some ideas about what we've been doing after I give you a bit of an overview about the overall problem and what's going on in Tennessee, and we wanted to address the pandemic as well and its impact on the problem of both substance use disorder and overdose, because I think most people have been hearing about that in the media. So I don't have any financial disclosures to make. I don't have any potential conflicts of interest, nor do either of my other colleagues that are presenting with me today. These are learning objectives, which you have seen. I'm guessing maybe influenced your interest in participating today. So I'm going to take you through some data slides pretty quickly, and then I'll pass the baton to my colleague who will tell you more about kind of our activities and sort of the scope of our work at the center. But I love this slide for a couple of reasons. It conveys an enormous amount of information in one place. And just as a warning, the next slide has a lot of variance on this same theme, but basically this is just a heat map relative to time. It's published in Science a couple of years ago, but effectively it points out how dramatically the overdose death issue came about, how it began to really increase in the early 2000s, and then up until the mid-teens was pretty striking. But what I want to call your attention to is this section right here. This is really the advent of fentanyl. Historically, the illicitly manufactured fentanyl, or IMF. Historically, overdose death had been an issue among older persons with substance use disorder, and particularly people who had kind of advanced in their hard drug usage over time to more and more and more increasing doses because of their tolerance. And so you see that here, and then continues to be an aging related issue. Look, 40 to 50 years old is what we're talking about here. But then all of a sudden, it came on strong over the course of about 8 or 9 years. And then this is really when we move from prescription opioids into heroin, and then heroin with fentanyl. As most people pretty much know at this point, this slide is informative because it basically breaks it down into multiple different drug categories. These are not just, the overall picture I showed you earlier is not just opioids, it's every thing combined. But what I would draw your attention to here is this synthetic opioids other than methadone. And this shows how dramatically that impacted the overall picture for both males and females, primarily males here, and then primarily white folks here, and then also in urban and rural areas. The prescription opioid overdose issue was more dramatically felt in rural areas, as you can see here. And that it's just an enormous amount of information that's conveyed here. This is cocaine, for example, and what's been going on with cocaine over the years. And you can see this has been, in terms of overdose, has been more of an African-American related topic. And then there's some noise in the data. This is unspecified noise, but this is still a lot of information to grapple with. Of course, heroin in this corner, you can see the dramatic increase. And this is a much younger group at this point. So just wanted to give you that for context and kind of lay out some of what's been going on. These are the hot spots for different overdose deaths by drug. And you can see that for different drugs, there are different hotspots. Fentanyl was really driven out of the cities and then into the suburbs, really kind of on the back of the heroin market. But as most people know by now, the prescription opioids problem really started in rural areas, was most prominent in rural areas. And of course, methamphetamine, as when this paper was published, methamphetamine market and overdose problem had been largely a Western US phenomenon, but that's rapidly changing. This paper is very interesting because it basically points out that there are dramatic differences in how acutely this problem is felt around the country. And I'm gonna kind of, the next slide's got a lot of words on it, but I want to take you through this for just a second. So these counties with that are in the colored shaded or brown or blue or red colors, those counties represent the 25% of counties in the US that have felt the problem most acutely. And of those, sort of what their local problem looks like. And if you break it down from those 25%, it looks like about 8.9% of counties have a largely prescription opioid problem. About 6.9% of counties they've transitioned to a synthetic prescription mixture epidemic, affecting both large urban cities and small rural places. Heroin epidemics concentrated in nation's larger metropolitan and smaller micropolitan cities. And lastly, a small share of counties, about 4.2%, are experiencing 3 coinciding epidemics of prescriptions, heroin, and synthetics. This is these are the spots in the darkest colors right here. So Southern Ohio, Western West Virginia, Western Pennsylvania, of course, Maryland, and then in the New England area. That has been the real driver. You can see Tennessee is still predominantly prescription opioid problem, and also in Southwest Virginia and in Southeast Kentucky. But just a little bit of context, what we're talking about relative to opioids is not just prescription opioids, it's not just heroin, it's not just synthetics at this point, other than methadone. I think this slide is important because it points to the difficulties that can lead to sort of a downward spiral in terms of economic opportunity for folks and otherwise. But as very thoughtful economist at Princeton named Alan Kruger basically began to call attention to the fact that people were dropping out of the labor force in a way that was highly correlated with the amount of opioids that were prescribed in that county. And so you can see the darkest green is high dropout or high decline in labor force participation and high opioid prescribing. If you think about that, less economic participation leads to less economic growth and can lead to longer term problems with folks, feelings of self-worth and gainful employment and so on, and in their basic economic positioning. And so there's just a lot to digest when you think about this and what happens to a community when people begin to drop out of the workforce. Of course, this has been a huge problem in our region. Wanted to give you a bit of, there are a ton of assets out there. We were fortunate to recruit the person who created this tool at the National Opioid Research Council, which is a division of the University of Chicago. We recruited him. His name is Michael Meat, and he's our deputy director for the Rural Health Research Center at ETSU. But he put this tool together as a project for the USDA. And they were very interested in, what's going on with this whole overdose problem across the country, and how is it impacted by different variables. And so you can go on this, if you just go to opioidmisusetool.norc.org, you can play around with this and just lay on different effects. In this case, we clicked on poverty rate. You can see the poverty rate, larger circles equal more poverty. And then, substance use facilities, for example, we highlighted the number of substance use facilities. You can see in Tennessee, there's 709. In this region here in Ohio is 922, and so on. But the point is that there are a lot of assets out there to help explain what's going on in a community. It can also help communities with respect to grants, grant proposals, and areas for prioritization. In Central Appalachia, we've seen a big problem related to employment and opioids, and driven by the disability and other things that are secondary to opioid misuse as well. There's a national study on youth that's done in, I think, 8th and 12th graders It's been going on for a long period of time. And in fact, it's very, very useful data because it demonstrates that the type of risk that youth see different drugs as posing to their health is basically negatively correlated with their use. So, for example, over time, you can see through the Monitoring the Future data that as youth have thought of marijuana as being risky for their health and dangerous, then use tends to follow about 6 months later. It turns out that on a population level, use is less. So peak risk perception is correlated with troughs in use. And then over time, they kind of converged and they crossed over. And at this point, marijuana use is not seen as being all that risky, but it is still very prevalent. And it's currently very prevalent among youth. That's the drug that is far and away the most common among youth, as folks know. Less so, cocaine or MDMA or heroin. We are largely seeing declines in substance abuse or misuse and substance use disorder, with some exceptions being in the amphetamine, inhalant, and cough medicine misuse. Overall, those three are all trending upwards. Just wanted to call your attention to that because if you're in psychiatry, you may be dealing with some of these issues. And, I think it's a complex topic. It's not necessarily leading to the same level of overdose deaths. We are seeing a lot of correlation between the misuse of methamphetamine and it leading to problems with opioid overdoses because they're being used together. I'll get into that in just a minute. So in Tennessee, what's going on in Tennessee? Well, Tennessee in 2018 was, I think, one of only 8 states that did not show a decline in drug overdose deaths, and continued to tick up in 2019. And we'll see in just a moment kind of how things are going in Tennessee relative to COVID. But overall, we've generally been increasing in Tennessee, and obviously had the highest number of opioid or overdose deaths in the state that we've ever had in 2019. And I suspect it'll be even higher in 2020 when we get the finalized numbers. Opioids being the driver, and then fentanyl and heroin increasing, and other prescribed pain relievers decreasing over time. You can see the raw numbers here. Now, stimulants have been basically, as folks have probably seen in your practices, you've seen more people presenting with stimulant use disorder, methamphetamine use disorder, and that's obviously borne out by the data. Stimulants other than cocaine is this green bar right here. The purple bar here is opioids and any stimulant. So you can see that that's really also contributing to overdose deaths. And then opioids and stimulants other than cocaine. Let me go back 1, 2, 4, 2. There we go. You can see the raw numbers down at the bottom, and you have access to all these slides because I know I'm presenting a lot of data here. In Tennessee, generally speaking, this used to be the hottest hotspot in the state, this northeast corner, and then it gradually crept westward in terms of overdose deaths. There's a lot of treatment options in our neck of the woods, so to speak. At this point, a lot of people are getting engaged in treatment. And Angela will talk in a little while about about kind of the shift in our focus toward basically supporting recovery ecosystems. So this has generally began moving west in terms of all overdose deaths combined. You can see in the Northeast region, we've had some declines in both opioids and, overall, and in opioids and in heroin overdose deaths. Now, these numbers are very small, right? So don't read too much into them, but this group of charts here in the middle of the slide are actually, have more numbers, higher numbers, and you can see better trends there. Sullivan region. So in our Northeast Tennessee health region, we have two regions. One of them is actually a metro, it's Sullivan Metro, but it's also classified as a region, presented in this way. And there's a bit of a different story in Sullivan County proper, with increases in heroin, increases in opioids overall, and all drug overdose deaths overall. Well, so what's going on with neonatal abstinence syndrome, or neonatal opioid withdrawal syndrome, more conventionally at this point, as it's known more conventionally at this point? Significant declines, and this is a huge win for, well, the baseline problem is still problematic, right? But there have been significant declines in NAS over the past few years. You can see the numbers in 2015 were up in the 1,000 range, and at this point we're down in the 783 range. This is the last week, I suppose, of the year. In the first week of this year, this is the cumulative summary for the state, and you can kind of see what's going on with this. This number associated with medication-assisted treatment has been high. It's been in this range of 60 to 70% overall, because that's a source of exposure, and that really has been largely due, I think, to folks getting engaged with addiction medicine providers and some of their practices not being necessarily aligned with practices that would prevent neonatal opioid withdrawal syndrome. But as folks begin to get a handle on high co-prescribing of benzos and things of that nature, we begin to see a decline in the problem. So relative to COVID-19, there have been a lot of calls in the media, relatively few studies about what's going on, but we have seen some pretty dramatic increases in overdoses in most places. Now, overdoses and overdose deaths have been an issue. When I break those apart, I really mean responses to overdose events through the use of naloxone or EMS being called to the scene to administer naloxone, and overdose deaths are obviously overdose fatalities. But we have seen pretty significant increases there, and there have been. Let me go to 2 slides from now, and I'll talk about this, and I'll go back for a second. There has been an effort to quantify this at the national level through a voluntary program called OD MAPS, that is high intensity drug trafficking areas that also have public health regions that report their data up to this system I think it's at the University of Maryland. And essentially what they showed was about a 17.59 or 17.6% increase in suspected overdose after the commencement of the state mandated stay-at-home orders. So, and we also, it was also correlated with the timing. This peak right here, in fact, was correlated with the timing of the stimulus checks. And you just can put 2 and 2 together. You got folks staying at home. You got people kind of sad, depressed. Yet they'll have a lot of other people around them. They're not necessarily using with other people, and so they are at higher risk for overdose at that point. So COVID-19 has in some ways really exacerbated the problem of substance use disorder and opioid use disorder, and it has been really frightening to watch. A couple of I'll cover this first, and then move on into the comments about the CDC report. But this is just a screenshot. Angela, do you want to speak to this real quick? Screenshot from basically a colleague who with whom we've worked in the past, and she's basically calling people out to check on people that they know have been struggling with substance use disorder, and I think it's a important thing to highlight here.
Yeah, certainly. Polly is a certified peer recovery specialist, very active in our region. And really similar to what we've seen in May and June when stimulus checks went out, we did see a sharp increase in overdose deaths. And sort of there are a number of reasons that might occur. And they're seeing it again. And so often we hear from our local folks, our local partners, what's happening on the ground way before we see it in the data. And I think it's really important to be able to intervene and pay attention to what our peers are seeing on the streets and in our communities. So I just thought it was important to notice that not only are we seeing the data and we know that COVID is really having a serious impact on our friends and family members, but even regionally right away, they're seeing increases. And so there's an opportunity for us all to intervene. And she put some of those opportunities to intervene and resources in this post.
Thank you. So with respect to Tennessee Department of Health, you can see increases here in red related to hospital recorded encoded opioid overdoses by month. This is May. Stimulus checks right here. And I'm not drawing a one-to-one correlation, but that is factually accurate. So it was that April to May timeframe. And you can see the other data here. We've got opioids excluding heroin and heroin relative to the hospital reported overdoses by class, and this is the May timeframe again, and then this is broken down by age right here with some increases there. But generally, COVID has broken a lot of things, and is any kind of progress that we were making on the whole SUD OUD problem, is effectively it's gone. Southwest Virginia, they've also been seeing some increases. This is the first quarter of 2021, and they saw, basically after COVID, they began to see some increases, in particular in the Southwest region of drug overdoses. Actually, the northern region as well, 32% there, but Southwest was 11% increase. So basically, these are just some recommendations from the Health Alert Network and CDC with respect to how we might be able to attend to the problem of the dual problems of both COVID-19 and synthetic opioids and other opioids, but expand the provision and use of naloxone and overdose prevention education, expand access to and provision of treatment for substance use disorders, providing stimulant use disorder treatment, and intervening early with individuals at highest risk for overdose, and then improving detection of overdose outbreaks due to fentanyl, using like test strips, fentanyl test strips, and things of that nature. And so I guess I have maybe 2 slides here to conclude with, but basically this is from a CDC report that came out in November, demonstrating where the increases were nationally in terms of overdoses and secondary to the whole COVID problem. So you can see there's been a tremendous increase. Now this is data only through May, and we don't know what has happened, but effectively in this report, there were, I think, 80,200 overdose deaths in 2020. I think that's right. No, I'm sorry, that was the 80,000 in the year in the 12 months prior to May 2020. So that was, they didn't do a calendar year for that analysis, but they were basically searching for the effect of the COVID-19 pandemic in this report. So tremendous increase in overdoses. We have been declining nationally in the problem of overdose death related to all drugs. We have been seeing an increase relative to the combined use of stimulants, methamphetamine and cocaine, and that problem has been getting worse as well. The data systems aren't necessarily robust enough to handle one epidemic, much less a pandemic on top of that epidemic. And so the whole COVID pandemic has really overwhelmed some data systems and toxicology, and testing labs and things of that nature. But generally speaking, from what I anticipate that folks are seeing and will continue to see for a while, it'll be, a lot more methamphetamine, continued difficulties with folks that are in isolation, and substance use disorders and isolating condition. So I applaud your work in psychiatry. You definitely have a very tough job, and we're here to help if we can. I'm going to turn this over to Angela now. She's going to talk to you about our team and what we've been doing over the past few years and share some different ideas with you.
Do you want to, you could just continue to drive, Rob, because I do have the two screens. I'm afraid I might mess things up.
Okay. Oh, well.
All right, so just go ahead and advance to the next slide. And thank you all. Hello, I'm really excited to be, it's been a while since I did a presentation, and so it's good to see faces and know there's folks out there for us to talk with about what's going on. And, we do always want to remember we share a lot of numbers, but each number is a person, someone's family member, someone's friend. And this feels like a very serious problem and sometimes insurmountable. But we are here to provide some options, some scientific opportunities for hope and intervention. And we do believe that, when we work together and implement these interventions across the continuum of disease, it makes a difference. And, I do think that some of the work that's been happening in our region has showing sort of what you saw was in some ways a decline in the overdoses in our region, where we used to be this dark red. It is looking a little bit better. And, again, I can't claim that any of our work has made that difference, but I do think that collectively, implementing both prevention and treatment has made a difference. And so going back with some of that history, in 2012 is when our working group began, and there was a community pharmacist, philanthropist, interested person, Guy Wilson. He went to the ETSU administration and he said, a lot of people are dying from this opioid epidemic, and I'm interested to know what ETSU is doing about that. And Dr. Bishop at the time said to him, I know a number of people who are doing some research, but I don't know that we're working collectively. So let's start doing that. And folks began to meet. Some of the folks that were in this picture, they met every 2 weeks. At that time, wrote some grants, and then have been meeting monthly ever since 2012. We now have over 350 people on an email distribution list. We've only missed one monthly meeting in 8+ years. And we've been pretty productive, as you can see in the next slide, Rob, that we, have been busy with our partners. We have put forward a number of grant proposals, a number of peer-reviewed publications. We continue to engage with our community in formal presentations. Students partner with us, and I meant to remove that yellow box. It is 10.5 million, I think. I wanted Rob to check my math. And as we continue to get some of these larger grants, those zeros on my little adding machine are a little tricky, but I do feel like the work and collaborators, the work that we've done with our affiliated faculty and community agencies have allowed us to be very productive. And in the next slide, you'll see that from 2012 to 2014, we were an informal working group working with our partners and faculty across the university. And in 2016, we were named the Center for Prescription Drug Abuse Prevention and Treatment. And things got a little more formal then. We began to look at our infrastructure. And the next slide, I think it is that you can see that we developed our mission core values. And I think that we really do prescribe to these values. Not only are we contributing to the scientific literature and investigating and exploring new hypotheses of how to intervene in substance use disorder, we also engage readily and regularly with our community. Our working group meetings are open to anyone in our community that would like to join. And sometimes we have, interesting debates about how folks feel about treatment and some things about stigma and chronic pain. And we just have very active discussions, but that is the purpose of our group and how we, what we feel is our responsibility to bring together folks to discuss what's happening in our region. And in the next slide, this is busy, and I think at some point we will be updating this. But when you think about the continuum of disease, sort of any chronic disease, it sort of starts on the left where folks are generally healthy. They're not misusing substances, and thankfully a good number of our population are in that category. And then we have sort of that first initiation of misuse, and it's different for each person and maybe different among age groups. But if we can intervene very early, when folks are beginning that initial misuse. So for example, the SBIRT program, screening, brief intervention, and referral to treatment that we're doing in family medicine, it's identifying folks at a regular, maybe primary care visit and screening them for substance use disorders early on, because we know if we can engage people and stop the misuse early on, you save so much trauma and death and suffering that occurs as you slide down the continuum from dependence to addiction. So we really would love to spend a lot more energy in primary prevention than sort of putting out the fires that we are now that we see from this epidemic. So this slide shows that as you slide across the continuum of disease, there are many multiple interventions that are evidence-based in each of these boxes that can be put at each level of primary, tertiary, secondary and tertiary intervention. And we do have a publication that sort of unpacks all of that with a compendium of resources that shows evidence-based treatments in each of those boxes along that continuum if you're interested. So the next slide, people ask me, what do you do at the Addiction Science Center? And it's really difficult because every day looks a little bit different, but we have 4 separate cores. And one is just sort of the administrative core, the people who are working full and part-time to sort of provide the infrastructure for grant writing and, engage with folks in the community, do grand rounds like this one. We also have patient care in the form of Over Mountain Recovery, a partnership with Ballad Health and Frontier Health that I'll talk a little bit more about in the next slides. And then a research, oops, sorry, I said next slide. And then our research and evaluation core, where we are doing, informing the literature and doing ongoing research. And then like we're doing today, education and outreach with our community. Okay, for real, next slide this time. And so that outreach and education core looks like engagement with local anti-drug coalitions. We are serving, we help them with grant writing. We're providing evaluation support for the Drug Free Communities Project at Carter County Drug Prevention. We support a number of evidence-based training and implementation in the region, parenting classes, serve on local, state, and national work groups. And if ever you're interested in sort of what we're doing on a monthly or weekly basis, we do track our news releases and our engagement with the community on our website. And our next is our clinical care core. And I would say that we're quite proud of the work that's happening at Over Mountain Recovery. We provide methadone, opioid use, treatment for opioid use disorder in the form of methadone and buprenorphine. We have over 330 clients, maybe more like 350 now. We take a variety of insurance options for folks that we have contracts with, I think 6 different insurance agencies. Rob, I think that's correct. Yes. And also grant coverage for those that don't have insurance. And not only are we providing medication, but excellent care and wraparound treatment services. So we're quite proud of the work there. You may remember in the next slide, some of these signs. It was not easy to open this clinic. It took us 2 years. Folks were very concerned that opening a methadone clinic, there are these images of what a methadone clinic is, and that if we opened it in their community, it would change everything, and that we'd bring crime and a certain type of people to their community. And we're proud to say that that has not come to fruition. We feel very proud of our clinic, and even news agencies have gone back and checked in with people, and they agree that things have gone pretty well out there. The next slide shows that there is just so much information about medications for opioid use disorder. Just years and years of research that shows that methadone keeps people in treatment and keeps them from using illicit drugs. It isn't necessary for every person. Different treatment works for different people, and it should be tailored to the individual. But for some folks, this can be just a life-saving intervention. And we did not have methadone in our area prior to Over Mountain Recovery. They had to go to another state. There's still so much stigma around medications for opioid use disorder. I see some of you shaking your head. It is really difficult. And we understand that stigma in some respects because there have been providers maybe that were in this business to make money. Maybe they overprescribed. Buprenorphine was diverted on the street. We know that there have been problems with the implementation and sort of this treatment, but also there's some other stigma that's very stubborn. We don't treat folks with other chronic diseases like diabetes and heart disease. We don't say that if they take their medications, instead of maybe changing their behaviors, we don't shame them for that. We don't say that they're swapping one pill for another pill or it's one drug for another drug, but there's something about substance use disorder where this stigma is just really stubborn. And so we're working very hard to continue to educate our community about the effectiveness of these medications. And the next slide is just another screenshot of just how, again, another compendium of evidence around the support for buprenorphine as well as methadone. So that was sort of our clinical care core and the struggles we've been through and some of the successes that we're having recently. Our research core, again, you saw before that we have a number of publications and a number of things that we can share with you if you want. Our new initiatives are the Opioid Research Consortium of Central Appalachia, and that was started with a partner from Dr. Kimberly Horn from Virginia Tech. She and Rob have a long history of working together, and we're funded by PCORI to start this consortium of research institutions across Central Appalachia, where we know that persons are more than 60% more likely to die of an overdose in Appalachia than non-Appalachian countries or counties in the US. And so there's a real urgent need to work together across state lines, share data, learn how universities can work together on grants and outreach efforts. And so this initiative was designed to begin to do that. It's more difficult than one might think to do research across universities. We're often competing for research dollars and publications and working sort of in our separate silos. And so this began the infrastructure for us all to work together. I think the next slide shows us the different institutions that were involved in the development of the Opioid Research Consortium of Central Appalachia. And our very first sort of successful project is in the next slide. I think it shows the studies. Oh, why create ORCA? Sorry about that. So this was, again, what I was saying is that essentially we were the epicenter of the opioid epidemic. There was a transition from the prescribed opioids to the illicit opioids, and now again the synthetic opioids. And prior to ORCA, there was no regional infrastructure that existed to convene these resources and workforce expertise. And so there was a need for it. And then maybe the next slide tells us what ORCA is doing. Yeah, which is, I think I've sort of already explained a lot of that. And so our first big project, our first big success was we did write our first grant. We figured out how to write a grant across multiple institutions, Virginia Tech and East Tennessee State University. This Studies to Advance Recovery Support is a R24 mechanism. And for those of you out there like me that have no idea what all these R's mean, this particular one is to develop research infrastructure. And we had our previous large grant in 2013 was also an R24 grant, and it helped us build the center here at the university. And now this will engage university and health system partners across Central Appalachia to conduct community engaged research, enroll medication assisted treatment clinics, or also MOUD, medications for opioid use disorder clinics, as they're sort of called, both of those things, engage peer recovery support specialists in research design, and better understand. We know that peers must be effective, right? We know that inherently they must be effective, but there isn't a lot of peer-reviewed literature that really explains all of the nuances of recovery support ecosystems and all of the work that peers do. And so we're looking to really advance processes and technologies, harmonize data, and look at how we can better measure recovery support services across our region and work together to implement those best practices when we know a little bit more about what they are. So this is a 5-year project. We're in our first 6 months of the 5-year project. And there are opportunities to become both a member of the Opioid Research Consortium of Central Appalachia, ORCA. From that website, you can become a member of ORCA, or also a member of the STARS Thematic Network, which is nested within the ORCA program. So I think, yes, and then separately, sort of a little bit different for us, we also were awarded one of the 7 rural health research centers in partnership with Michael Meat, who Dr. Pack talked about a little bit earlier. So it's called the Rural Health Equity Research Center, and we do a number of very quick data, primarily data-focused research projects that inform policy in rural America. And so it's not just in Central Appalachia or Appalachian regions. And the projects that our center is working on are focused on substance use disorders, but our partners over in public health and health services management and policy and our Center for Rural Health Research are doing other rural health policies. So we're partnering to do something that is a little different, wider across the nation with a more broad rural focus, but then again, honing in on some of those opportunities to understand substance use disorder in rural America with the projects that we're doing in our center. And so stay tuned for more of that. We're learning a lot about, Rob and I talk about all of the new acronyms we're learning with rural health, but we're excited to be doing that because we do see that rural areas are more impacted, are impacted differently by substance use disorder than urban areas.
So three of the 4 projects that we'll do in the first year of this center grant are related to substance use disorder. One is on the cost of treatment in rural areas. Second is on buprenorphine. Well, it's actually a secondary data analysis using Medicaid data in rural and compared to urban places relative to buprenorphine use among pregnant women and outcomes related to that. The third is on moving, the different factors that have led to children being displaced out of the home. And most of that is related to, well, not most of it, but a lot of it is related to substance use disorder by parents, and also engagement with the criminal justice system and other things like that. And that's, I guess, 3 of the 4 projects. The 4th is actually not pertinent here, so I won't talk about it, but that's kind of exciting to begin to orient a bit more to the national level, and with really strong partners at the NORC. Angela?
Yeah, I think that pretty much covers it. I mean, certainly we would be happy to entertain. I know we've got a little bit more time left, so entertain any questions or discussion about the data or how we can partner together. So I would just open the floor up to any questions.
All right. Well, thanks to both of you for that very informative presentation. We'll go ahead and take questions if you want to unmute yourself, or if you'd prefer, you can use the chat feature. Yes, Dr. Miller.
I really appreciate your talk, and I've been concerned about the neonatal abstinence syndrome problem for some time, and I'm curious to hear more about your current thinking on how to decrease this, because I'm aware that there's been controversy as far as what has been recommended by some groups for maintaining methadone or buprenorphine versus other evidence that women can successfully decrease or possibly eliminate their use of opiates during pregnancy. And I noticed on one of your slides that prescribed opiates is the most common cause of NAS. So what is your current thinking, and are you encouraging women and educating doctors about the option of reducing or eliminating opiates during pregnancy?
Well, I appreciate, Dr. Miller, your question. That is a topic about which I'm not qualified to weigh in. Okay, so I really don't have the clinical expertise and training to talk about whether or not it is possible. I will say this, that there are a couple of universities that have been engaged in that topic, ours being one, UT being another, and there have been studies that have been published about, voluntary reductions in buprenorphine dosing down to lower levels, with the authors pointing to positive outcomes. Now, having said that, I am not a clinician. I'm not going to weigh in on that side of it. Other clinicians here can weigh in on that if they would like to. But those are just some details about what's going on. It is somewhat controversial. I think, there's some really good science going on relative to this topic at Vanderbilt with Stephen Patrick's group. We've got some good scholars here in the state that are working on this. I can try to present something on this more in a more comprehensive fashion at some point in the future, but I'm outside of my area of expertise relative to clinical recommendations.
Yeah, and if possible, I mean, we do get asked this a lot in presentations. And so I do often point folks to ACOG and other places where, in general, for the most part, it is encouraged that women are maintained on medication and offered medication during pregnancy, because the risk of relapse and maybe the lack of resources that they might have to wean. And so I do think that this is something that we do talk about. I am also not a clinician, but I have a lot of I do read on this topic a lot. And so I've sort of heard, I think we all would hope that any woman that is suffering from opioid use disorder would be able to not be on any substances at all by the time she delivers her baby. And I mean, I think that with the right supports and doctors who can help them wean, for women that are willing to do that, I think that is, I'm really glad that some of the science is happening in that regard. And Dr. Pack mentioned some of those. And again, for a lot of women that don't have those resources, it's very important, I think, to also recognize the current general recommendations from ACOG, which is to continue to keep them maintained on an appropriate dose. So when we see the NAS chart that says that many of the women have opioid use disorder because of a prescribed, that isn't necessarily a bad thing. Those are women who are engaged in active treatment upon the recommendations of ACOG, right? They're being prescribed it. It's worse when we see the numbers of women who have unprescribed and illicit opioids showing up with NAS. So it would be better to see that they're prescribed and in treatment than those that are not. And so I think people often see that number and they think, well, that means we shouldn't have women maintained on medications for opioid use disorder when they're pregnant. So yeah, this is a really good conversation. And I hope that the studies continue to sort of give us better evidence about what exactly should happen when a woman has opioid use disorder and is pregnant.
Thank you.
Well, other questions? Are there psychiatrists or psychologists or other, perhaps psychiatric nursing professionals and others that would like to get engaged with our work? If there's anybody there that wants, anybody in the audience that wants to join with the working group, we'd be glad to have you. Just drop in. We'll send me an email or Angela an email, and we'll get you connected to the working group. And we meet from 4 to 5:30 on the second Tuesday of every month. And really, for the hour and a half long meeting, the first half of it is really us introducing ourselves and to each other and just finding out what people have going on. I find that to be the most valuable. We have several of our members here today, and essentially what happens is, somebody will say kind of the project that they have going on, and others talk about theirs, and then by the third or fourth person, people tend to say things like, hey, have you ever met this other person? Let's make a connection. And it's a bit like focused networking, if you will, on this topic. And the people that tend to keep coming back are people that have been working on this problem for a long period of time and have other activities going on relative to it. So we'd be delighted to have more clinical care providers in the group, particularly in psychiatry. Will be fantastic. And so we would invite you to join with us if you are interested. No obligation. It costs nothing but an hour and a half of your time once a month in the late afternoon too. So you can do it on the way home, or we're doing it via Zoom for the past year. And
Well,
probably,
that sounds like a really great opportunity. You said just email you all for that.
yeah, email me or Angela, either one. I'll put my email in the chat function here.
That's what I was just going to ask. Thank you.
You can also, if you forget this, you can just find that way to contact us via our website. And, there's a little box there. You can just put in your question or send us an email from that program.
Great,
Dr.
thank you.
Pack,
Yes.
Dr. Pack, when I send out the credit reminder for everyone today, I can attach the presentation in a PDF version so they have the data available to them if you would like that. And I can actually add yours and Angela's email if that would be convenient for you all.
The presentation is going to be pretty problematic to email because it's 283 megabytes. I noticed that today. So I would send a link to it, maybe a Dropbox link or something like that. But yeah, please do include both of our email addresses. And we're glad to
do that with the
And I mean, I think, Brian, you shared the link for today's slides on Google Drive, right?
Correct.
Perfect.
Yep. And so that's in the chat feature if anybody wants to click on that or copy it.
Yeah, you can also send that around via email. That'd be great. We try to share we give away everything for free, hoping that somebody will possibly use it someday.
Thank you for that resource.
Absolutely.
Thank you.
Any other questions? Well,
Very good presentation.
Thanks so much, Dr. Miller, and thank you everyone for your time. Thanks for the invitation, and we'll look forward to hearing more from you at some point in the future.
Great, thank you so much.
Take care.